Glycoprotein 2B3A receptor antagonists. They block, they block the receptor because it is important for the platelet aggregation. It is taken through IV infusion, not orally, because they are not effective orally. They have been licensed in high-risk patients undergoing a coronary angioplasty, and it's added in heparin and aspirin, so it's taken with heparin and aspirin as well. Adverse effects is bleeding, especially with anticoagulants. So phosphodiesterase inhibitors or adenosine uptake inhibitors, they work in two ways. They will inhibit PDE. They will inhibit PDE, which then will increase CAMP. So phosphodiesterase usually will break down CAMP. It will break down CAMP. But if you inhibit phosphodiesterase, CAMP will increase, and CAMP increasing means that platelet aggregation will decrease. So phosphodiesterase inhibitors will increase CAMP, and the inhibition of adenosine will increase adenosine in the plasma, and the adenosine will work on A2 receptors, increasing CAMP, decreasing platelet aggregation. And it also, adenosine also causes vasodilatation in coronary arteries. So dipyridamole, it will potentiate the effect of prostacyclin, and therefore decreases the adhesion of the platelets, and it also is used as in combination with aspirin to prevent a stroke. Cilostazol is used in intermittent claudication. It's a vasodilator. It's taken orally, and it is not used in heart failure, so contraindicated in heart failure. So the two C's are used. The two C's are used orally: cilostazol and clopidogrel. Both are used orally. Thrombin receptor antagonists, vorapaxar and atopaxar, they inhibit the binding of thrombin to its receptor, which would have caused again the aggregation. So they are used together with the aspirin and clopidogrel, and to reduce the risk of heart attack and stroke in people who already have had a heart attack or have problems with blood flow in their legs. Then you have aspirin, cyclooxygenase inhibitors like aspirin. So aspirin is irreversible. It causes irreversible acetylation of COX in platelets that will decrease thromboxane A2, and that will last for like 7 to 10 days because it is irreversible, and platelets cannot form COX again because it has no nucleus. So you will have to wait until the platelet dies, right? Then it will also inhibit COX-1 in the endothelium, and PGI2. So it will inhibit PGI2 will decrease, but since endothelium has a nucleus, it will resynthesize COX, and thus PGI2 will be resynthesized, and it will have it will exhibit its effect of vasodilatation and inhibiting of the aggregation. So aspirin will be used in low doses because it prefers COX-1. So in low doses, it activates or inhibits COX-1. And in so it works as an antithrombotic. And in high doses, it will inhibit both COX-1 and COX-2 and work as an anti-inflammatory drug. So low doses is like less than 100 milligram per day. Therapeutic uses of aspirin is prophylactic treatment of transient cerebral ischemia, in recurrent myocardial infarction, and decreased mortality in the setting of primary and secondary prevention of myocardial infarction. ADP inhibitors or P2Y12 receptor inhibitors, clopidogrel, prasugrel, and this has been taken off the shelf, but we will talk about it. So clopidogrel and prasugrel inhibit irreversibly. The ADP usually binds to P2Y12, which P2Y12 then increases the expression of GP 2B3A, which is important for the platelet aggregation, right? So if you inhibit that, you decrease ADP, then you will decrease the aggregation. So clopidogrel is a prodrug that is activated in the liver by cytochrome P450, which there are major interactions with drugs that inhibit liver microsomal enzymes. You take it orally, and its maximum effect is in 3 to 5 days. So you can use a loading dose to achieve the maximal effect rapidly. Clopidogrel is approved in unstable angina, myocardial infarction, stroke, and a stent. It has side effects like bone marrow suppression, and the prasugrel has a risk of bleeding as well. So ticagrelor inhibits reversibly. Its maximum effect is in 1 to 3 hours, and it's used to be used in prevention of ischemic stroke and with patients with recent coronary intervention. But since it causes severe neutropenia, aplastic anemia, and thrombocytopenic purpura, it is not used anymore, so it's no longer available in the United States.